will start mastering how to report ejection fraction and all these things, because machine only is calculating all that. So many patients who are having the persistent foramen ovale, they have some amount of redundant atrial septum. It is otherwise called atrial septal aneurysm, and this aneurysm typically is the one which will promote the shunting. But otherwise there is no reason why shunting should happen in the case of a persistent foramen ovale. Absence of the shunting is against the protection against paradoxic embolism, hence it is more likely in the case of the PFO is what need to be remembered. Echocardiography with a agitated saline bubble contrast is another wonderful way by which the right to left shunt can be demonstrated, and both the pulse and the color flow Doppler studies can be able to enable us to know which is exactly a predominant direction of the flow is what need to be basically understood. Transesophageal echocardiogram, does it have any role in identifying the ASD is a very important question. Sometimes transthoracic may not be optimum, there you can basically use, but generally transesophageal echo is more wonderful for imaging the left atrium because it is more a posteriorly located chamber. So this is a typical transesophageal echocardiographic view where you can see the left atrium, right atrium, and this is the LVOT, left ventricular outflow tract, which is originating basically from the left ventricle, and right atrium draining into the right ventricle. So you can see the flow pattern which is happening between the two. So there is a reason transesophageal echo can also enable you to basically quantify. Radionuclide flow studies also can quantify by giving a bolus of contrast within the lung fields by observing it, and typically by defining the recirculation you can be able to make out, but generally clinically it is a 2D echo, the Doppler studies would be more than sufficient and significant. Now what is the role of the cardiac catheterization is a very important question. Generally there can be certain associated defects along with the ASD. The 2D echo may not be able to quantify it significantly enough, especially if you are planning to correct the ASD. If you do the cardiac catheterization of the right side of the heart, you can exactly reach the chambers of the heart. So in that scenario, to know what is the size, what is the location of the shunt, to measure the pulmonary vascular resistance and pulmonary arterial pressure, and also to know whether there is any anomalous pulmonary venous drainage also as an associated finding. For all these purposes, right heart catheterization is much more definitive, is what I want to underscore to all of you. And nowadays we have wonderful umbrellas. Those umbrellas will go and open up and patch the ASD. So percutaneously only, without open heart surgery, you can be able to close the ASD. That is another important purpose of doing the cardiac catheterization. Patients who have got a small shunt will live a normal lifespan, and those who have large shunt can suffer from disability by the age of 40. And because the left to right shunt tends to increase as the age advances because of the LV compliance, it is very important that just because shunt is small, you can't say that let us delay the closure. I mean, because there is no right to left shunt, let us delay the closure is a wrong outlook. Because though the pulmonary artery pressures are increasing and the right ventricle is about to fail, still the right to left shunt may not establish. The reason is, along with the right ventricle, the left ventricle also lost compliance due to the aging. Because of that, there is a rise of the LA pressure, and because of that, still the shunt is continuing left to right. That does not mean, if the left to right shunt is there, does not mean the right ventricle is suffering. Right ventricle is very much suffering, but left ventricle suffered more than right ventricle. Hence the shunt remained as left to right is a very important caveat which should not be forgotten. So increased pulmonary vascular resistance and the pulmonary vascular disease because of and leading to the development of the pulmonary hypertension, there are some of the important reasons which can cause the Eisenmenger complex to develop is what I want to underscore to all of you. Now the question is, the development of this Eisenmenger complex, is it more likely in the case of the ostium primum or the ostium secundum defect is my question to all of you. It is more rarer in the case of the ostium secundum type, whereas it is more common in the case of the primum defect is